Hello, everyone, and welcome to the HealthyXSundays podcast, where we bring you the most critical and actionable content in the nutrition and fitness space. Dev from Mind Muscle Pro and myself, Kunal Jain, also known as Veg Diet Coach, are your hosts. Today, we are thrilled to welcome Dr. Andrew Kuttnick to the podcast. Dr. Kuttnick is an award winning scientist and a leading expert in metabolic health and type 1 diabetes management. With over 100 scientific publications and collaborations with renowned institutions like NASA, Harvard, and the Department of Defense, Dr. Koutnik has dedicated his career to translating cutting edge research into practical strategies for health, performance, and disease management. Living with type 1 diabetes himself, Dr. Koutnik combines personal experience with scientific expertise to empower others to take control of their health through nutrition, exercise, and lifestyle changes. Get ready for an inspiring conversation about bridging science and action for optimal health and performance. Thank you, Doctor, for making time for us and welcome.
Hey, it's an honor, guys. Truly appreciate the opportunity to be here and speak with you guys, answer questions, yeah, let's do it.
Great. So let's start with the growing medical health crisis. What do you see as the main drivers of the current metabolic health crisis, and how can public health efforts address these root causes?
Well, that's an easy answer, I think. I think because there's not much controversy, and I'm not about to throw something out there that not everyone will expect. It's certainly there's a number of things, of course, but the food environment is a big problem, right? It is a big issue. The access, the type of foods that people are consuming certainly don't appear to be assisting them on their journey for better health. It certainly seems to be doing the exact opposite, promoting overeating, and that combined with a lot of conveniences that modern 21st century has brought about reduces physical activity. And so you have this combination of many people are over consuming, not necessarily to their own fault. Oftentimes subconsciously there's a desire to overeat the foods that are readily available for most people that are often inexpensive, are the ones that people are most apt to consume. And as a result, that certainly seems to put people at a lot of risk for consuming excess calories, not burning many of them, so being more sedentary and less active. And that combination certainly leads many people to become ultimately overweight and then ultimately obese. And when we talk about the growing metabolic health crisis, that seems to be one of the fundamental pillars that is driving many of the issues that we are seeing at unprecedented levels. Not just, of course, where I live in the United States, but across the world. In India, the rates of type 2 diabetes are reaching a peak level, and these numbers don't appear to be slowing down. They seem to be going on an upward trajectory. And so there's certainly a number of reasons that extend beyond that that are a bit more nuanced, but those are clearly key drivers of why people are struggling right now. And the rates of many diseases have gone up, and not all that's obesity related, but a lot of that can be tied back to some of the same problems: the food, the lack of activity, and some other exposures that people may be getting throughout their life that puts them at greater risk. So yeah, it's complex. It's much more nuanced than what I described, but I think those are the key pillars that are driving a lot of these issues.
And are there any public health efforts which can address these? Do you think anything which is happening now in America, like the Make America Healthy Again movement, any
It,
significance?
that's Yeah, that's very interesting because there's never been at least just from my awareness, a greater level of highlight or a greater spotlight on some of these fundamental lifestyle problems: poor nutrition, lack of activity. That's never, in my opinion, gotten the level of appreciation and exposure that it has recently. And I am hopeful that that will lead to a number of positive changes across the board. There's obviously the emergence of very, very powerful anti-obesity medications in the context of GLP-1 receptor agonists. And those have been shown basically over and over again over the years, because they used to have oral forms, and then they got them into injectable forms, and that allowed them to be sustained for longer in the body. Essentially, the medications became way more effective due to technological advancement, and that got to a point where it became extremely effective in individuals. And so there's that to consider as well. There is the interest on a political level to potentially address some of these root problems in society that are leading in a lot of incentives for people to develop foods and products that maybe aren't in the best interest or for people's health, and maybe make it difficult for people to sustain health. But then there's also another layer to that, where there have been some remarkable technological advancements that really may allow for some individuals who have historically struggled to overcome some of these key challenges, to have a tool finally in their toolbox to address at least one of the root causes of some of these metabolic health crises, which is a problem with overconsumption, or the problem of being hungry or consuming even when maybe someone doesn't have the perception of hunger, just for the seeking of a positive response. And so that emergence and the emergence of drugs are only getting way more powerful is another layer to this. In fact, there's some public interest in some key individuals on a political level who've been talking about this, and certainly not going to be one or the other. These are all in consideration or on the table for addressing these issues. So the only thing that has actionably happened, to be totally frank, is the emergence of these medicines, because we have been talking about change. We know that food works. Most people know that changing your diet works. The problem with changing your diet is that people don't know necessarily how to do that or where to get information to do it effectively. That's a major difficulty and problem, because you can go anywhere on the internet and look for resources and find a lot of misinformation. And that may lead you to fail on the approach, and then ultimately feel discouraged, and then just repeat the cycle. So that's obviously not helpful. When someone's looking to engage in physical activity, a lot of times they're looking at these elite level athletes and saying, okay, well, if I want to be great, I have to do what they're doing. And that's also terrible approach to do. Everyone wants to be like like in America in basketball. If you want to be a basketball player, you look at LeBron James. If you want to be a sprinter, you might look at someone like Usain Bolt or some of the emergent sprinters. And but that's a bad approach. These people never started being that great. They worked at a different level. They started by taking a step, then they took steps, then they started started to jog and then run and then sprint. They never started there. At least most people don't. And so for most people, it's just about starting and taking the first step in physical activity. And then, all these things combined, there's a whole list of helpful tools out there for people to improve their health, but most people are having difficulty engaging with them, or finding effective approaches on how to do it. And these have created a lot of barriers. So I think in general, I'm hopeful that the next few years will lead to a revolution in metabolic health, but you never can guarantee it.
Absolutely.
Right. So speaking of revolution, the emergence of the international therapeutic carbohydrate reduction has been nothing short of a milestone. So why do you think, even like it's been delayed so far, like so long? Like why do you think there's so much resistance against acceptance of carbohydrate restriction?
Yeah, so carbohydrate restriction, for your audience, for them to know, it is very controversial. It has been very controversial for a number of years, but it's important for people to understand that this has actually been around for hundreds of years. It was actually standard of care before the discovery and Nobel Prize of insulin. And so that should ease some people's apprehension, because it's not new. This has been around for frankly centuries, to treat obesity, type 2 diabetes, and type 1 diabetes. The lack of guidelines is quite an interesting story, because the first emergent nutritional guidelines for people with diabetes in general was in the 1960s from the American Diabetes Association. And the American Diabetes Association made the statement at this time that people with diabetes should eat the same food as those without diabetes. And so about 10 years later, they kind of doubled down on this philosophy. But keep in mind that that kind of stuck for a few decades. And that was despite never having evidence to support that claim. It was more of an assumption that those with insulin now available, they should be able to eat the same foods as those who don't have the disease. And I believe that was a misstep. I think that was an error in assumption. And as a result, it caused a set precedence in what is and isn't healthy, not based on evidence, but based on assumption. And as a result, that led to many people believing that doing the opposite of what was set in stone based on these assumptions was maybe not the healthy approach or something that you should do because it's different, it's restrictive. And then there was also this convoluted precedent set because it was used for seizures or people with neurodegenerative disorders or for seizures for 100 years. But the way it was being implemented was initially extremely restrictive. So over 90% of the calories from fat. And that's a very difficult and often unsustainable way of doing the diet. And the vast majority of people who say I'm doing a ketogenic diet are never doing this traditional ketogenic diet, which is a 4-to-1 ratio or 90% of the calories from fat. I mean, that's mostly a liquid fat form of the diet. People don't appreciate that's not what they're often doing, but that was what was done in the medical literature for seizures, even at Johns Hopkins, not too much further back than like 20, 30 years ago. And so when kids were looked at for these diets, there was often a large number of kids with refractory epilepsy who were able to see remarkable improvements. Not everyone improved, nor would you expect that in any intervention, but many did. But there was also reports that some of these children also had maybe issues of growth. The issue with that is that that was an extreme form of the diet that most people would not implement or sustain, with low protein levels, altered calorie intake, a whole bunch of reasons why that would not be representative of the traditional approach. And so this led to assumptions that, okay, well, what's happening in that extreme form of the diet is going to happen over here in a more well-formulated, higher protein, more balanced approach. And there's all these hypothetical risks that started to be proposed by many people in the medical establishment, which was, hey, one of the biggest issues more than anything, especially in type 1 diabetes, for gaining some level of appreciation for this approach is that ketone bodies, if anyone has heard of this before, that really got a bad rap from the disease I have, which is type 1 diabetes. Because that is what was elevated at extremely high levels. That was the one thing to distinguish someone for having the onset of type 1 diabetes, and they end up in the hospital. And some people often died because these ketone levels were getting so high. And lack of awareness, people said, okay, what must be the ketones that are causing these patients to get sick and some die? And it was never the ketone bodies that were the problem. In fact, the last 10 to 20 years of evidence has shown that these are remarkable therapeutic metabolites with a lot of health potential. It was the acid load that was a byproduct of ketone metabolism when insulin is completely absent, which is almost never the case in any other physiological environment. That acid load becomes so high so quickly, the body can't adapt quick enough to it. And as a result, it causes acidosis, something called diabetic ketoacidosis. So just at first glance, people think, okay, well, if you're going to do a diet, that I've heard of this diet called a ketogenic diet. Doesn't it elevate ketone bodies? And aren't ketone bodies what hurt patients with type 1 diabetes? Well, no and no. But that's the assumption people were going to, historically speaking. And actually, that's still, unfortunately, around. But there's a number of other reasons that people are apprehensive about this approach. But a lot of that is based in hypothetical and unsubstantiated risk, often due to misinformation. And so the reason we, in a group of other individuals, specifically Beth McNally, Amy Rush, Francisca, Caroline Roberts, a team of international experts and people often living with type 1 diabetes or treating patients with type 1 diabetes, with over 10 reviewers from around the world, came together to build guidelines because there were none. what was happening is that there were signs of evidence of this remarkable therapeutic potential of lowering carbohydrates in diabetes. Specifically, what I'm talking about here is type 1 diabetes. But we also know for years or a century that people for type 2 have used this approach. But there were never any guidelines for type 1. And there were many healthcare practitioners that were seeing patients come into their office and just starting and doing this approach. And they would often reach out to me. Maybe they found me on a Google search or something along those lines, and would say, I don't know what to do here. How do I help this patient? And this is from some of the best diabetes institutes in the entire world experts in treating diabetes. But the problem here is that if you're a medical professional who is treating a patient, you often have to do so under the guise of something called standard of care. And these are based on guidelines set from major institutional bodies that allow for clinicians to follow a set criteria by which they can care for patients. If they step outside of that path, they run the risk of, if something doesn't go right, that someone could come after them in their medical license. And so the problem is that no one had ever wrote guidelines for type 1 diabetes in low carbohydrate nutrition. No major institute had. They had written guidelines for type 2 diabetes in adults, but never for type 1 diabetes across all age groups. And so many healthcare practitioners felt unsupported. In fact, there's evidence from Annalyn Conklin's group, who's a well-known epidemiologist at University of British Columbia, surveyed clinics and found that many healthcare practitioners, specifically people who were experts in diet, dietitians and nutritionists, either one, didn't feel supported by their healthcare team to implement carbohydrate restriction, or two, they themselves felt uneducated on how to do the approach. And over 66% of those dietitians and nutritionists who were surveyed reported this. So 2/3 felt unsupported or unprepared to do this approach. Well, why would that be? Why would it, one, be unsupported, or two, they felt they didn't have enough resources to do it correctly? Well, almost certainly the rationale for that is because there were no guidelines. There was nothing out there that says you can do it and do it safely this way. And so I reached out to many of the major institutes and said, hey, look, you guys have a problem here. People are doing this approach without any healthcare support. In fact, the evidence also supports that most patients do this with minimal or no healthcare support in type 1 diabetes. I'm hearing from endocrinologists and dietitians and nutritionalists and certified diabetes educators, et cetera, all over the world at some of the best institutions that they're asking me, what do I do? This is a huge problem. Hey, look, you guys don't have it in your guidelines. How do I address this? And you need to. Well, that was over a half a decade ago. And so we kept asking, kept pushing, kept saying, hey, we'll help with this. And essentially just got to the point where the community themselves, the people who were supporting people with this disease, the people who were living this disease, decided that we were going to do it ourselves. And we decided to build international institutional guidelines for the first time ever from people who not only lived with this disease, treated this disease, researched this disease from many levels of the healthcare rung, whether it be a physician, endocrinologist, primary care, to a dietitian, nutritionist, or certified diabetes educator or researcher. And we brought those individuals together, and it was ultimately put out by the Institute for Personalized Therapeutic Nutrition, which is an international-based organization that supports individuals implementing safe approaches for nutrition to treat disease. And so it gives people the opportunity to look for and actually find resources to help them guide their patients on the journey, because as these people want to help their patients, but in the absence of resources, in the absence of guidelines on how to do that, they could be at risk. And so I like to say that this was guidelines that were built by the community for the community. And that was really the goal, to address a major gap. And I'm hopeful that it translates to helping many patients along their way.
Right. So, like you mentioned, you are a type 1 diabetic. So that obviously played a major role in you finding interest in this field. So how was your journey? Like, How did it all start? How did you discover about the whole diet and everything else?
Yeah, I was diagnosed 16 going on 17 on a family vacation, hundreds of miles away from home. Was in a hospital for 2 weeks, realized immediately how much goes in this disease, how overwhelming it could be. Um, and then you kind of just settle in every day to accepting, holy moly, this is this is going to be intense. I'm going to have to know everything about lifestyle, nutrition, how much insulin I have to inject into my body to regulate this powerful molecule called glucose in the body that can be essential for life, but also extremely damaging to tissues if left on abnormal levels, high and variable levels. And so for me, the journey was actually a unique one. It wasn't like I said, oh, hey, look, I'm looking at this textbook that's 100 years old and they use this approach. Let me try it. That'd be a cool story, but that's not actually how it happened. I was at a time in my life when I was younger, I wanted to be bigger, stronger, faster. So I was looking to I was fascinated about powerlifting, strength sports, athletics, and also bodybuilding. And so I was looking to become as big and as strong as possible. And I was fixated on this. And I had heard at the time of this ketogenic diet. Now, the way it was being presented was inappropriate. They portrayed it as magic. Nothing is quite magic. It can do some remarkable things, but it's not magic. And they portrayed it as if you could do it builds muscle and shreds every ounce of fat off of you, which, although there's ounces of truth in this, but it wasn't the miracle per se that many people were portraying it at the time. But it was a very helpful tool, and so I tried it. But what I also found is, before that time, I had actually come across a professional athlete who was living with type 1 diabetes. And I had reached out to them because I thought, hey, look, I would like some guidance and help on my journey. And that's something that is for guidance for anyone out there who's looking for help on, trying to figure out how to do something the right way, or hey, I'm trying to get better at this or that. Look for someone who's doing it. Look for someone who's done it well, who's succeeding in life, who's, if nothing else, maybe achieving the top percent of their field, and look at them as an example. How did they get there? What are they doing? And so I became this individual. Ultimately, ended up helping me navigate my journey with type 1 diabetes very early on in my diagnosis. And I asked them about this diet, and they said, sure, I think it's a great idea, but hey, these are all the things you need to do it right. You need to change the type of insulin you're giving. You need to consider how you administer with food. It's a similar level of education as you get when you first get diagnosed with diabetes. Hey, this is the type of foods, this is how you administer insulin, this is the type of insulin, here's how exercise and other aspects of lifestyle will affect it. It's a whole new level of education when it comes to doing these lower carbohydrate approach, because it can fundamentally completely change your metabolism and physiology. And as a result, insulin, how glucose enters the body, how it elevates glucose, how it's different, these all change. And so this individual had already done this and was helping me as a professional athlete, utilizing it, decade ago, well over a decade ago. And ultimately, they helped guide me on how they did it. And it actually was almost instantly within 3 months. This is before they had CGMs. This is before, you could pull your phone up and go, oh, look, I have a sensor on my body called a continuous glucose monitor. And, you look at these things and, you see, well, it's blurred out, but, it helps tell you where your blood sugar levels are. And I didn't have that at the time. And so, I didn't have this clear 24/7 insight into what happened in my blood sugar when I was doing this diet. What happened was that I walked into my doctor's office, who happened to be the American Diabetes Association president and a remarkable endocrinologist. And he comes into the room and says, Andrew, what are you doing? And I looked at him and I'm like, okay, well, something must have happened. What's on that sheet of paper you got there for my blood work, and he said, I've never seen an HbA1c at this level before. And for your audience, HbA1c is an average of your blood sugar over a 2 to 3 month period of time. And what that number showed is that my blood sugar was in the completely normal metabolic range. So meaning my blood sugar was averaging below HbA1c below 7.5%, and millimolars, I believe that's 6.5 or around 6.6 millimolars or less than that. And I was in the normal range, but I had type 1 diabetes, something that over 99% of people with type 1 diabetes will never see a number like that. And he had never seen one in his office. And so he brought out the medical students. He got me to go speak to the medical school, all sorts of things along the way. And that really opened my eyes. Like, I was doing something special. Not only was I doing something special that other people were telling me must have been special, but I felt different. I wasn't having these highs and lows and fluctuations. I felt more stable. I started to perform better in all aspects of life, not just physically, but also mentally, emotionally. And that's really what started the journey for me to realize, not only, had I dealt with obesity as a kid and lost weight and realized how powerful exercise and nutrition could be then, but when I got diagnosed with type 1 diabetes, a disease where you are looking at glucose, insulin, and self-managing all of them every ounce of every minute of every day, that took my appreciation and passion for these things to a completely new level. And that's what brought me here. And that's what brought me to ultimately care so much, not just about type 1 diabetes, but the ability to translate lifestyle tools, i.e. lifestyle medicine, to people, whether you have a disease or not, to improve their wellness, to mitigate the disease or prevent disease in the first place, or in many cases, ultimately optimize physical and cognitive performance.
Right.
That
Kunal, yeah.
that's great. I mean, congratulations to you and the team who got the TCR published. 100 years is a long time coming, but glad that it finally is available for all the people to take take advantage of. And now talking about your groundbreaking study on the 10-year ketogenic diet case, what are the key takeaways and what implications do these findings have for managing diabetes and improving metabolic health?
So you're referencing two studies that we recently published in the last 6 months. These two studies were actually looking at a very unique case of a 10-year sustained ketogenic diet where body composition, calories, physical activity were all controlled over that period of time. And obviously you have 10 years of aging in a disease. And this disease that we were looking at was type 1 diabetes. And at this time, having looked through the medical literature and also looked at all the studies ever published in type 1 diabetes where nutrition and carbohydrates are reported, the longest anyone had ever even reported being on a ketogenic diet was 4 years. And the longest someone had actually reported change values. So they had data before they did the diet and after they did the diet, or even throughout. The longest that had ever been was less than 2 years. And so there was nothing remotely close to this period of time. Now, even outside of type 1 diabetes, the longest report ever outside of type 1 diabetes in any condition utilizing a ketogenic diet, where they had data both pre and post, was in GLUT1 deficiency disorder. And that was 10 years. But that was in a neurodegenerative disease where they just observationally assessed individuals who had retrospectively used the diet, or individuals who showed up, said, I was doing the diet and I've been doing it for a period of time to manage the disease. And they look back at their health records. Well, what was so unique about this circumstance is that, one, the timeline obviously is unprecedented. There's really nothing like this in the literature. But the controls that were in this were the control of body composition, calories, physical activity, things that we know change health and change the biomarkers we looked at. But what did we look at? Well, one of the common criticisms of these lower carbohydrate ketogenic diets is that it can elevate something called LDL cholesterol, or low density lipoprotein. And this is a molecule in the body that, when elevated, has been associated in the general population with elevated cardiovascular disease risk. And so there was so much focus and highlight around the concern of raising that. And when you do this diet, you can often reliably see elevations in LDL cholesterol. Now, keep in mind that when you have a disease like diabetes, the risk for cardiovascular disease is tenfold higher. And in type 1 diabetes, where kids are often diagnosed, you can see the early signs of atherosclerotic progression, the signs of changes in the vascular wall, early signs of what would eventually become plaque buildup, can be seen within 4 years in kids who are diagnosed with type 1 diabetes associated with the levels of glucose. So the higher and more variable the glucose levels, the more out of normal range they are, the more damaging you would expect this cardiovascular, the more damaging glucose is to the vascular wall, and ultimately causing early progression of the disease, the cardiovascular disease, the number one killer in many parts of the world, but certainly the number one killer in diabetes. So what we did that was unprecedented is that this individual had controlled all these variables, but also had a sustained elevation, almost a doubling of LDL cholesterol over that entire 10-year period. And it was untreated, meaning they didn't take statins, they didn't change their diabetes management protocol. It elevated. And so it was a amazing opportunity to see what was the cardiovascular implications of having the sustained elevation of LDL cholesterol. But this was a unique case where the patient also illustrated something unprecedented. They were able to achieve a 10-year sustained level of glucose that was in the normal glucose range in type 1 diabetes. This is unheard of, and was unheard of anything over a 4-year period, even observationally reported, but this was confirmed over a 10-year period with a confirmed change on diet. And so we were able to very uniquely monitor what were the changes in this individual's health with an advanced assessment of cardiovascular disease progression. This was done by someone in collaborations with ourselves and someone named Joe Watso, Austin Roberts, and others, who we actually did early advanced workup of the cardiovascular physiology of the patient. And that allowed us to see these early signs of vascular change that we do reliably see within 4 years. These changes occur in even kids with type 1 diabetes. And so what we did is we were looking at these early signs. And then once we gathered that data, we compared it not only to equivalent individuals in the type 1 diabetes community from large data sets, but also people without type 1 diabetes who were age, sex matched controls as well. And what this data illustrated was that when an individual went on this diet, sustained a healthy lifestyle as well, that they achieved remarkable sustained glycemic control, had no adverse events throughout the entire period. So no adverse effects on bone mineral density. In fact, despite 10 years of aging, they sustained their bone mineral density. No adverse effects on kidney, liver, thyroid function. But when looking at the cardiovascular health of the individual, in a disease where you're at tenfold higher risk for having cardiovascular disease, and it occurs very early, there were not only no early signs of cardiovascular disease, but this was actually the cardiovascular metrics were actually oftentimes better than people who didn't have type 1 diabetes. And what this really highlighted was the potential power of nutrition in the context of a disease where nutrition is a very underappreciated component, as was asked earlier, often controversial. But this really introduced a potential powerful methodology for sustaining what appears to be clinical therapeutic and efficacy and also safety. But keep in mind the limitations of this is that this case per se isn't a large randomized controlled trial. It isn't even it isn't hundreds of people. That means it's limited. What if it could or it could not apply to others? We don't know that answer yet because we don't have that evidence yet. But what we do know is that it was possible, and that it was remarkable outcomes were achieved. And so the question now remains is, as the evidence starts accumulating for the possibility of this approach and evidence illustrating it could be safe and effective, despite the hypothetical concerns that have been raised, which in this report we illustrated there were no adverse effects against any of these hypothesized risks, the question now remains is, what should be the optimal nutritional approach? And I think there needs to be a serious reconsideration of what that is in the context of diabetes. And in this case, we're talking about a report on type 1 diabetes.
That's
Right.
very interesting.
So, like when somebody is designing a ketogenic diet for their whatever the condition is for type 1 diabetes or anything else, so how do we get this fat to protein ratio right? Like, what is the optimal ratio? As you rightly mentioned earlier, if it goes somewhere around the 90% fat mark, it can more or less not be sustainable, and it can be a trouble. So how do we get that ratio right? What is the optimal mark, and what are the factors on which we decide this?
Great question. So that is up to the purpose that someone is doing the diet. So when we talk about these first ever international institutional guidelines for type 1 diabetes, a lot of the discussion was not about doing this approach with like a 90% fat or 4-to-1 ratio ketogenic diet. It was around having a sustainable higher protein approach to the diet that's well formulated for various whole food, nutrient dense food ingredients. But if someone's doing the approach, they could be doing it because they want to lose weight. Maybe they just want to feel better. Maybe they're doing it because they themselves have epilepsy or their child does. And so they've heard of the literature on ketogenic diets and helping assist with attenuating seizures. Or it could be a number of reasons why someone is considering this. And frankly, there is no one size fits all situation for everyone. If they wanted to do this approach or they had a reason they were doing this approach, each one has a nuanced consideration to it. But one general guideline on this approach is that when you start the diet, there will be a transitional metabolic transition. It's often reported as something called, it's an unscientific term, but it's often used, called keto adaptation or fat adaptation. So we know that's going to occur for most people because most people are on a high carbohydrate approach. And so most people should at least be prepared for that transition, being prepared to have the appropriate minimal supplementation until the body fully adapts, like sodium, potentially magnesium, potassium. That's an important consideration. You also need to account if you actually have a disease, if you're lowering carbohydrates, oftentimes in diseases like type 1 diabetes or type 2 diabetes or others, it means an almost instantaneous reduction in medication, especially insulin. Or if you start losing weight on the approach, if you're let's say overweight or obese and you wanted to lose weight, and so you're doing the approach to help you have a sustained approach to weight loss, well, then you also need to consider the weight loss as it would be a positive thing for that person, but that also affects, let's say, if they're hypertensive, their blood pressure medications. Or if they're type 2 and they're on insulin because of insulin resistance to manage glucose levels, that might mean a reduction in insulin requirements. And so you also have to consider the co-founding nature of the powerful therapeutic potential with other things people are why they may be implementing this. There's also the consideration for performance. Some people want to do this because they want to maybe have some of these health-related benefits, but also have considerations for physical activity and physical performance. And we've done a number of studies in this category. And suffice it to say, it's important to also consider the adaptation timeline, particularly around physical performance, because a lot of the literature that shows changes, at least negative physical performance effects, are very short term, meaning when someone first goes on this diet and they first transition, you can see a lot of literature that says, okay, you might not perform optimally for a few weeks until you undergo a number of key physiologic and metabolic changes. And so understanding that if you are on this journey, you need to find a sustainable way to do it, because ultimately a lot of the benefits that people might be utilizing it for often come through habituation, sustainability, and sticking with the approach over time. And so however you look to formulate this approach, it's important to look to keep an eye for that in mind. And that might mean for someone looking at their current diet, looking at when they eat, what they eat, how they eat, and then finding what components of that are consistent and would be consistent with a very low carbohydrate or therapeutic carbohydrate reduction approach, because that's already a part of what someone's doing. And so it's not a major change to keep those things. But then you look at the things that you're doing that are not compatible with the diet, and you can remove them. You're going to have to remove them, but then you can also find ways to supplement those. That could be, hey, I really loved sugar in my coffee, or I love barbecue sauce, or I love a certain type of Thai sauce, whatever it might be. You can look for recipes online that allow you to replicate that same flavor profile, but do so with ingredients that are consistent with lower carbohydrate dieting. And that's completely achievable. In fact, one easy tool is you can just go to Chat GPT and just type in, hey, I want to eat this food. How do I make it ketogenic? And I've used it a lot, and it's been right every time so far on how to do it. So at least in my anecdotal experience, it's a pretty solid approach if you're lost on the diet and trying to find fun recipes. But there are a number of great websites now that people can go to try to do it. But what I highly recommend is find out why you're doing it, number one. Then once you know why, look for people or communities or individuals who are succeeding doing it that way, and then find out how they're doing it. Because that's one of the best strategies you can ever do, is look for people who are succeeding. Don't look for people who are failing. Look for people who are succeeding doing what you want to do. And ask, how did you do that? And once you hear that from enough people, you might find at least some consistency which can help guide you on your approach. Once you find that, look for people who are experts, who understand this, who know this, maybe on a personal level with experience, but also maybe educationally. Maybe they research this as well. And that's a great way to take the steps to find the information that's evidence-based, that's almost certainly likely going to help on the journey, and removes a lot of pitfalls from people finding misinformation along the way.
That's right. And you have a lot of research on your website, and there is some regarding artificial sweeteners. So, would like to ask you, what are your recommendations for choosing or avoiding artificial sweeteners, and why are these decisions significant for metabolic health?
Yeah. So there's huge implications here, because why would someone do an artificial sweetener or add a sweetener? Because people like sweet flavors. It's not, and it shouldn't be wrong for that, right? People love, that's why sugar has become the enemy for many when talking about metabolic health, because we know that sugar is often overconsumed and it's highly palatable. It tastes super good. So you want to consume a lot of it. And so when people are trying to find effective strategies to lower caloric intake and lose weight, sugar is one of the easiest places to look to say, oh, you should probably reduce that. That'll help reduce your caloric intake and lower calories. So like things like sugar in liquids that you can drink, that's like a low hanging fruit to try to remove that from the diet to lose weight. But people still want to feel that same level of satisfaction from, let's say, their coffee if they had sugar in it, or they want to make for a cake, for a birthday cake. They don't want it to taste like like sourdough bread. Maybe they want it to taste like a sugary cake. And so there are a number of ways of doing that. And historically, people look to artificial sweeteners. So chemically induced or chemically created sweeteners. And some of those include things like sucralose or aspartame or one of these other types, because they taste sweet. They may taste similar to sugar, maybe not identical. But the problem with including them is, one, yes, you are replacing a lot of calories in the form of sugar with something that tastes potentially very equivalent that doesn't have those calories. That's a huge win for people to have that. The problem, though, is that some of these aren't benign. Some of these actually appear when consumed at high enough levels for a long enough period of time that originally the research says, well, doesn't really look there's any potential harm. At least most of the literature. If you looked at animal data where they consumed it at high levels over a long period of time, you did see concerns. But if you looked at some of the human data, it really didn't show a lot of harmful effects. But then there was an emergence of data in more controlled trials where they were administering something called sucralose when consumed over sustained periods of time at levels that people actually do consume them in everyday society. We're developing things like insulin resistance. And this really raised some alarm bells for a lot of people because that illustrated they're not just a supplement for glucose to lower calories, but they're actually potentially harmful if consumed consistently over time. Is it still better than consuming a ton of calories and sugar? Probably. But is it for free? No. At least some of the data suggests that. So then the question is, what should I consume if I still want to have some sweet type of flavor? And so generally speaking, people have shifted towards away from artificial sweeteners to naturally derived sweeteners. And that could mean things like monk fruit, stevia, or allulose. Now, when you look at the literature, there is some actual emergent evidence in these different natural sweeteners. And it certainly seems that these appear to be very, very safe sweeteners. But even because a lot of them are derived from fruits like dates or other ingredients, they just concentrate it and you can consume it. And things like stevia or allulose or monk fruit, that reduces a lot of concern because if it's coming from a plant, doesn't mean it's necessarily healthy, but it definitely makes you feel a little more comfortable than consuming something that's completely artificial. Because if it's in a plant that we have consumed, at least we know what small quantities that was in that plant that should in theory be safe. But artificial, you never know until you actually try it and include it for long enough in someone's diet. So of those natural sweeteners, if they're inherently appear to be safer just at first glance, and also the evidence seems to suggest that, which of those do you choose? And that's a very interesting question to me, one that's way more interesting to me now than it ever used to be, because a lot of, well, not a lot of these, but some of these are actually not just sugar alternatives that are extremely low or have no calories whatsoever. I have observed, at least in some of the emergent evidence in animals, but also in myself, that there is some potential metabolic effects of some of these natural sweeteners. And one of those is actually allulose. So the reason I'm so interested in this topic is because for so long, I viewed these as just caloric substitutes. Okay, you have all this dense calories and sugar that you get very little metabolic benefit from. In fact, it could be metabolically damaging, especially consumed chronically over time. Just remove those. Okay, if you can just remove them and provide something that tastes similar and gets people off sugar, win. But then when I'm starting to look at the literature of something specifically like allulose, you start seeing all this emergent evidence in rodents that say it has this anti-obesity and anti-diabetic effect, specifically type 2 diabetes. And okay, you say, okay, well, is that just reducing weight? Well, no, there's actually a lot of what they call incretin effects of this of sweetener. Now, what's interesting about allulose is it's what they call a C3 epimer of fructose. I'm sure many people have heard of high fructose corn syrup. It's almost certainly the devil or the terrible form of sugar. It's super highly palatable, has negative health consequences. Fructose more so than glucose does or sugar does. And so many people have heard of how terrible that is. Well, it's actually a C3 epimer. So you take one of the molecules and you flip it. Well, by flipping it, one, you still get the sweet flavor, but you make it largely non-digestive, meaning that it's not metabolized into ATP, and then as a result is calories. But it is absorbed by the body, and the body does process it. And what's interesting is that it induces a high elevation of endogenous GLP-1. It also appears in animals. It also appears to lower glucagon and ultimately lower glucose. And then as a result, also lower insulin. But these are all in animals. Well, there's this emergent evidence in humans that when you consume this, it also has a potent effect on having similar incretin effects in humans. So emergent evidence says that it also induces endogenous GLP-1. And if you induce or elevate endogenous GLP-1, then you're talking about these other changes as well, like potential for lowering glucagon and other effects from something that has virtually no calories and does taste sweet. But then there was these two studies, again, very preliminary, but that has suggested that people who are overweight and or obese when consuming it with sugar, it can attenuate the impact of the glucose, how high the glucose, so an oral glucose tolerance test in essence, not exactly one, but analogous one, it blunted the glucose rise, but also lowered insulin. So that's a remarkable potential of something that tastes sweet and is an alternative to sugar, but that might have a positive metabolic effect. But then there was another study for individuals who underwent Ramadan. Now, Ramadan is a religious practice where people don't eat for extended periods of time. And what they found is that people with type 2 diabetes who were during Ramadan, when they added allulose to their refeeding, so when they refeed during Ramadan, just adding allulose blunted the glucose rise of that meal. But it was a very uncontrolled setup or study. But we're about to publish some emergent evidence, the first ever in type 1 diabetes, in a very controlled setup that I think will open a lot of people's eyes to its metabolic potential, not necessarily as a just safe, natural sugar with a sweet flavor, but actually having powerful metabolic potential, therapeutic potential at that. And so it's not out yet, but when it does come out, I'm looking forward to sharing it with people to highlight that, not all sweeteners are the same, natural versus artificial, but even all of the natural forms, not all are metabolically equivalent. And that's for sure. In fact, Ben Bickman's group out of BYU has recently published some work in animals showing that, having allulose on top of a Western diet reduces caloric intake, obesity in animals, but also Paul Reynolds at BYU as well, who studies glycation. So this process of how glucose attaches to tissues and potentially can cause damage or inflammation within the body, something called AGEs or AGEs. And he also published a study showing the potential of allulose to attenuate the accumulation of AGEs as well in cells. And so there's more to come for sure. And this emergent study is going to be highlighting in humans. And so this will be, I think, a really eye-opening assessment for people to see.
Right. Very interesting. So earlier this year, there was this case of a 25-year-old, I believe it was from Beijing or somewhere, where stem cells from her own body was used to regenerate uh, beta cells. So what is your thoughts on this? Like that, if that really works out, then it's like opens up a lot of possibilities.
It certainly does. So that we have to take a step back. So why and talk about these type of restorative therapies. So in general, when people talk about stem cells, the way they think of them is these cells that are these early undeveloped cells that may have the potential to turn into any tissue. So the initial thought with that is, oh wow, if you have tissues that are damaged or unrecoverable, like in type 1 diabetes where the beta cells are killed, can you use stem cells to redevelop them, regrow them, and then they're functional again? Wouldn't that be amazing? Or let's say someone has damage to a tissue, like let's say individual needs a kidney transplant because their kidneys are lacking function, or tissues within that tissue are so far damaged that are unrecoverable. Could we use stem cells to regrow or grow back tissues that were being destroyed or are ultimately being damaged over time? That's the potential that stem cells held. Well, this emergent study, it looked at the use of stem cells where not only do you take the stem cells, you didn't need to take them from other individuals. In fact, stem cell therapy was such a controversial thing in the United States because where they were taking them originally was embryonic tissue, because in the embryonic tissue, there's they're very potent, powerful stem cells in embryonic tissue. So fetuses or babies, when at birth. But that became very controversial. And how, you don't take those from these individuals, or, it became a political issue. And so that actually forced scientists through because of policy barriers to look a different direction. And so what they looked at was the ability to take tissues from or cells from tissues like fat, and actually used certain chemical molecules in a laboratory setting to take fat and then cause the fat to almost have stem cell like properties. And that allowed for these tissues that you can easily take. People do take fat tissue or other tissues all the time in laboratory settings. If you could take that tissue, turn it into a stem cell, is there the possibility that we don't need to take tissues from things like fetuses or babies, and it comes from the individual themselves, and then utilize that to regrow tissues in that person? And the answer to that in this case report, was yes. What they did is they were able to take fat cells, put them in a laboratory environment, turn them into stem cells, utilizing a very unique method. They were then taking those stem cells and turning them into beta cells that produced insulin, because in type 1 diabetes, your beta cells are destroyed and or gone. So you don't have the ability to automatically regulate insulin anymore. And so then they take those beta cells and were able to transplant them into an individual. And they use a very unique transplantation site, because depending on where you put these cells, they appear to be more or less effective. So they put them in the area, the lower abdomen in this case, and they found that utilizing this unique chemical or this unique extraction technique from a person, then a unique chemical and induction of stem cells, and then unique ability to turn it into beta cells, and the unique injection site actually allowed for a person to get completely off insulin and essentially become as if they didn't have diabetes at all. And so this is a rather remarkable advancement in general. But is that going to be the cure? Does that mean that me, Andrew Kuttnick, is going to no longer have type 1 diabetes in such a short period of time? Or that Johnny or Jim or Angela, whoever it might be, who just got diagnosed, are they going to have to not worry about their diabetes in this case, or type 1 diabetes? Unfortunately, the answer to that is no, because they've actually been studying stem cells and curative therapies for decades. And the biggest reason, in fact, there's a paper in the year 2000 that quite literally changed the entire field of type 1 diabetes, because they showed that they were able to take islet cells, transplant them, and achieve completely normal glycemic control. That revolutionized the field. It revolutionized the thought process of getting this disease as that, here soon you're going to have a cure, so don't worry. Did that happen? No. Here we are 24 years later, almost 25 years later, and we don't have a cure. In fact, the best we have is preventative therapies that may delay the onset by up to 2 years. But you'll eventually still get the disease. And the reason for that at its core is that in this specific case, and in many cases where tissues are damaged, the immune system actually has changed. And that immune system change has caused the body to now see things like beta cells as a target, or tissues that ultimately facilitate insulin production and release. And they see it as a target. And so as a result, even if you restore those tissues, the body's still going to target it, because the immune system still sees it as foreign and or an enemy like bacteria or a virus. And so until you fix the immune system, you will never completely cure someone, because this specific patient had to remain on what they call immunosuppressants. Immunosuppressants are ways to dampen the immune system's response to injecting tissues the body sees as foreign. The problem with immunosuppressants is that chronic immunosuppressant use has side effects and risks on the order and magnitude equivalent to many of the risks and side effects that having the disease itself of type 1 diabetes without a cure has. And so what you're really talking about here is the possibility of just allowing someone to have normal metabolic function, but they have to remain on this drug over here that has a lot of side effects over time. So what will really be revolutionary is when they take these curative therapies and then actually make it so that the immune system is no longer attacking it and is able to keep it in the body, sustain glucose control, and not have to worry that it's going to die off in due time, because that's what inevitably happens. In that first study in 2000, where it revolutionized the field, all the patients got back on insulin, most regressed back in HbA1c, and many gained weight because now all of a sudden they're on insulin. They have insulin management, and now they're having the same problems the general population has, because, with overweight and obesity. So there's a lot that still needs to be done here. And so the key message and take home here is that if you are diagnosed with type 1 diabetes, you should be hopeful, but you should not look at these advancements as a means to not pay attention to manage your disease today, because we don't know when that's coming, and it may not come in my lifetime. I hope it does. I hope it comes tomorrow. But if it doesn't, you should not wait to improve your health. And that's an important message for people to appreciate, is that we can all wait and be hopeful, but don't put expectations to fix your metabolic health and improve your overall well-being into the hands of hopeful scientific advancement that may or may not come.
Excellent. And can you share insights from your special forces study on ketone metabolites and its implication for performance and metabolic health?
So we have been studying exogenous ketones for quite a long period of time. And we talked about this earlier. If someone's just now tuning in, ketone bodies were something that were originally appreciated in the context of type 1 diabetes as these really damaging metabolites that cause acid to rise. But the last 10 to 20 years, we realized that ketones were never harmful. In fact, in these normal ranges, on like something like a ketogenic diet, or when you fast or undergo prolonged exercise, or a combination of these factors, that you can have therapeutic impacts. In fact, we now appreciate that ketone bodies have anti-inflammatory, antioxidant effects. They can change your gene expression, something called epigenetic alterations. They have robust metabolic effects, and they have robust signaling effects, a lot of which have been associated with positive health outcomes or mitigation of disease-related issues. And so that brought about a lot of interest in various communities, particularly the military community, because there's a funding agency, the same funding agency that led to some of the most major developments in society. People often attribute the internet being developed by some projects led by, at least initiated by, DARPA in the United States of America. But DARPA also funded the development of an exogenous ketone molecule out of Oxford, and also the National Institutes of Health, by someone named Richard Veach and Kieran Clark. And they developed a way of developing something called a ketone monoester. Now, what was that? Well, it was a way of allowing someone to not have to go on a ketogenic diet, but consume this oral material that would allow for ketone bodies to elevate as if you had been fasting for 4 to 6 weeks instantly. I mean, we're talking within minutes, instead of it being, hey, in order to get a level that high, you'd have to fast for, days to weeks, or do a ketogenic diet for a long period of time. Now you could just consume these molecules that elevates ketone bodies within minutes. And so that led to a lot of remarkable potential. And so some of their initial studies showed that not only did they have remarkable metabolic effects, but that they also improved physical performance. Now, this was a study in 2016 in a high prestigious journal called Cell Metabolism. And these were high-end athletes who showed a 2% performance. When people think 2%, what does that mean? That's not revolutionary. You have to pause for a second. Number one, they compared it to gold standard approaches. So you add ketone bodies on top of gold standard, and it improved it. So that's a pretty important stipulation. Number two is that 2% improvement is extremely meaningful when you're talking about the winner and loser in almost any sport, because usually the margin of first, second, or sometimes well into the pack is much less than 2%. And so this could be meaningful, right? So what has then happened is a number of studies over the last almost 10 years, it was 2016, we're now 2024, and various formulations of ketone bodies, various dose administrations of various types. One of the exciting things that has come out of that is that, one, we're learning how to potentially apply these molecules, because they don't always, or in the right type to apply them, and when to apply them. The advancements in carbohydrates as a performance enhancing tool, frankly, has been going on for half a century. And we're about half a decade at this stage in the exogenous ketone work and to performance. But what that has shown is some of the recent work we did was funded by Special Operations Command and the Department of Defense, is where we engaged with this community to understand not only what was their needs. And so what you see in these elite level operational performers is that not only and it's important for the audience to appreciate, when we talk about elite level performance, a lot of people think about sprint performance or physical performance, how fast you run. But there's levels of performance that aren't just physical, they're also cognitive. Okay. And in the context of military or special forces, it's cognitive and physical together at the same time with the highest stakes possible. And so Special Operations Command was very interested to understand, could these metabolites that have now shown these emergent metabolic and signaling properties that may be beneficial, can they apply to have health implications or performance implications in these extremely high level operational individuals? And so what we did is we were testing it in one of the challenging environments that military personnel may engage in, and that's hypoxia. A lot of people, when they think performance, they're thinking, okay, well, I'm going to run on a track for 100 meters. But what if you need to go into an austere environment, such as a mountain range? You need to not only engage in chronic or elevated levels of physical activity, but now you need to cognitively perform at a level that it could mean life or death. And so that's the composite nature. You could be sleep deprived. You could have lower caloric intake. You could have all these different interactions that go into it. And so one of those stressors is something is like hypoxia, and that doesn't just apply to military. That could also apply to someone who's going to race in a mountain range, or like Tour de France, where they're climbing mountain ranges oftentimes within a day that can lead to meaningful changes in elevation that change physiology. And so one of the challenges with hypoxia or high altitude environments is low oxygen availability, which can cause declines in cognitive performance. They absolutely can lead to declines in physical performance. And so what we did and what we were interested in is we were interested in the potential cognitive enhancing effects of ketone bodies, because there was literature going back a half a century showing that ketone bodies could replace glucose as a energy metabolite in the brain. And so we also knew that there was evidence on ketogenic diets and seizures, and a whole bunch of other evidence that led to this idea that this could be a powerful augmentic tool or ergogenic tool in these environments. And so we took individuals and put them at 20,000 foot altitude, and had them engaging in very demanding cognitive tasks. So we would put them in this controlled setting and in controlled environment and try to just truly isolate out the question: if you add these molecules into this controlled environment, military personnel, do they improve performance? And despite putting people at 20,000 foot altitude, so equivalent to Mount Kilimanjaro, the tip of that, not quite Everest, which most people, frankly, you don't survive at Everest. If you put it at Everest immediately, it would be life threatening within minutes. But Mount Kilimanjaro is one of the highest mountains in the world. So suffice to say, it's very, very high. And your ability to sustain cognitive function is actually minutes at that level. And what we found is that when we administered ketone bodies, number one, it did improve cognitive performance. What it was doing was it was blunting the decline in performance from normal oxygen levels to lower oxygen levels. So it was providing resilience against the lower oxygen availability on cognitive performance. But what was even more fascinating to us was that it appeared that the administration of ketone bodies was actually elevating the level of oxygen that was saturated in the blood. Now, how is that possible? How was ketone bodies increasing oxygen levels in the body? Well, we had no idea. I mean, we were seeing meaningful elevations of ketone bodies in the blood, and enough to where we thought, oh, wow, there's a significant effect in physiology from these molecules that we would have never expected, that ultimately was associated with this enhancement in cognitive performance. So we then took the next step, because it's important. I will highlight here in a minute how we think this is happening. But we also want to do this in the context of exercise, because if you put someone at 20,000 foot and they do cognitive demanding tasks, what happens when you also incorporate exercise in the mix? And so we had this massive chamber that individuals in this incline ruck. So a ruck is a weighted backpack that's could be anywhere from 50 to 100 plus pounds that someone puts on their back, and they're often climbing up mountainous terrain. And this is a very demanding task, much more demanding in low oxygen availability. So heart rate's exceptionally high, very demanding physical activity task. And we asked the question, if you're doing this military relevant physical activity, what happens in hypoxia now? Because we also know in the context of exercise that exercise has its own independent cognitive enhancing effects. So if you were to go for a run or go engage in some extremely difficult exercise that really elevates your heart rate for a long period of time, this often leads to improvements in cognitive performance in individuals for a number of mechanisms. And what we found in this setting is that it appeared to again improve the oxygen saturation level. And what we also found is that it appeared that the means by which ketones were potentially improving cognitive performance might be overlapping with exercise. Because when we looked at historical studies and our findings, it appeared that when a lot of the mechanisms of physical activity performance seem to overlap with ketone based performance. And we're still baffled by this idea that oxygen levels were higher. And what it's interesting is if you look at the standard of care for someone who goes to altitude, let's say you go from sea level up to a mountain range and you get sick. So something called acute mountain sickness, where you can get, you get insomnia, you have headaches, reduced performance, you can feel sick to the stomach. This is a symptom of low oxygen availability. One of the medications that are provided, in fact, medications provided almost ubiquitously around the world and in various settings, including in military settings, is Diamox or acetazolamide, which what it does is it increases oxygen availability in the blood. How it mechanistically works is it actually causes a mild acidosis in the body, not a dangerous level, but a mild acidosis. And when you drink these ketone bodies, it also induces a mild elevation in acid load, not one that would be damaging or counterproductive, because obviously we saw an enhancement in cognitive performance, but this mild acidosis appeared to model the same physiology that these drugs do. The problem with the standard of care drugs is that all the literature right now suggests that these drugs reduce physical performance and cognitive performance, which particularly in a military setting could be extremely, extremely life-threatening, right? If you're taking a drug to relieve your symptoms of altitude, but at the same time, it reduces your cognitive physical capabilities, that's problematic. And so it's exciting about the possibility that even in the context of this work, that we're seeing these abilities to reduce the impact of hypoxia and improve cognitive performance. And it seems to model some of the physiology of what people have done for years, which is use drugs to reduce mountain sickness. But this may be an alternative path that doesn't have the negative cognitive physical performance, in fact, appears to improve cognitive performance in these settings. And so there's a lot more work on this front, a lot of work in the military, Department of Defense range and beyond, because there's a lot of interest in finding ways to improve optimal and elite level performance, not just in athletes, but in operational environments and in other highly demanding environments as well. And so the research is continuing in this front, but that was our most emergent work. We've done a lot of work in physical performance and other settings with ketones as well.
It's so awesome that you're translating all the cutting edge research into language which laymen can understand and take benefit from. And the example of the latest study which you have done, I think it can be extended even to the commoners, because a lot of people in India would go to the Himalayas, they'll take a Diamox and still get high altitude mountain sickness. So it can be a wonderful thing even for people who go trekking and all these things, right?
So and that's a really great point, because a lot of the follow-on assessment, because this is very initial, this is very preliminary, this is like very early stuff. So so in essence, there's a lot more work to be done on this front, but it opens this whole new area of opportunity for people to to, yes, not just an individual who's trying to perform at the most elite level, but what if someone's going to a visit somewhere and they're getting symptoms, and maybe they can't take Diamox, maybe they don't want to take Diamox. What if they take alternatives to that? Or what if there's a different way in which they can approach that problem that has potential benefits for them? And that's an extremely exciting possibility. And I can promise you there's more work to be done, because people perform at altitude. People are going for vacation reasons. There's a whole bunch of reasons why this is relevant for the general population. But yes, there's a lot to be done on this front.
Right. So to wrap up, just some questions which, how can someone like improve their metabolic health from your experience? Any 3 pointers you want to give them?
Pay attention to the most important thing. Oftentimes people get dragged down the nuance, and they think, okay, well, I need to, I heard the study about glycation, and if I do this specific like this specific supplement at this level or this drug, that it will tweak that just 10%. That when most people are starting on their health journey, they just need to focus on the most important things. One, are you eating appropriate and well formulated nutrition? Are you eating a healthy diet? It may not have to be a ketogenic diet, but are you approaching your nutrition mindfully to consume foods that are going to make or improve your health, or at least not put you at risk for health deterioration? That's number one. Number two is physical activity and exercise. If you were to put the pillars of health, nutrition is certainly one of them, but exercise is absolutely another. We were made to move. And when people sit and are active or inactive for long periods of time, it clearly has negative implications for people's overall health. And so when people can get up and start moving more, almost all the evidence says that there's almost no setting where exercise shouldn't be done. Even in heart failure patients, they have done studies with high intensity interval training, again, under supervision, of course. You just don't go do something like that out of the blue. Someone who has heart failure, you just don't run at max speeds, but it's just going to show that those people saw health improvements. And almost all the evidence says that the more physically active you are, of course, in a safe way, over time, the healthier you will be, the lower your risk are for other diseases, the longer you may live because of the lack of having other diseases on your health span. The third thing that often has a remarkable impact, but most people don't really pay attention to, especially in the developed Western world, is sleep. And when we talk about the three pillars of health, one, two, three, that hold up the foundation of metabolic health, it is nutrition, it is exercise, but I would also put sleep in that category, because the lack of it is consistently associated with negative implications in health, also impacts how people consume and eat food, also impacts their desire or ability and the response to exercise. And so that is a huge implication on overall health. And it's often, in many people, dysfunctional, and people don't even realize it. They may over caffeinate or have too much stimulants, and then they're on this terrible cycle of not sleeping. So those three areas are critically important. And before anyone really should be talking about anything else, they should be trying to address those three components first. It's equivalent to trying to put new rims on a car, or a shiny sticker or bumper plate on a car that doesn't have an engine, doesn't have a chassis or an axle or wheels. Like you need to have an engine, you need to have a chassis and the foundation of that vehicle, and it needs to be functional. Then you can start worrying about the other details along the way of what ultimately can help improve even beyond those three pillars, and also specific to you. Because even if someone tells you, hey, this is the optimal approach, then you have to do it for your health. Realize that ultimately, one, you need to try it, because if you never try it, you'll never know. You have to try it. That's number one. So take the first step, give it a go. Then you have to ultimately find out, does it work for me? No matter how much someone is telling you this works and it's amazing, if it doesn't work for you, you have to listen to your body. And so trying and then adapting, try and adapt until ultimately you're finding what works best for you as a person, because we're all slightly different. in different ways. And in science, we provide recommendations based on the average of how people will respond. But at an individual level, we know that these interventions and approaches are going to have variable effects on individuals, and each person has to find out how it works for them and trust how they respond to it ultimately, because that's going to be the most important thing on their individual health journey.
Excellent. And doctor, there was one audience question from Twitter, and this is regarding it's a personalized question on the person is a type 1 diabetic and is a vegetarian and is using keto and wants to know that how should I weigh in my dietary fats when calculating basal insulin?
So, so number one, most people don't think it's not often you hear someone who's also vegan and or vegetarian and doing low carb. And this person illustrates it is possible. I've definitely known some athletes who are interested in doing that for either a number of reasons. It isn't always health reasons. It might be their own personal philosophy in life why they choose a certain diet, right? But so fat does have an effect on insulin levels, particularly in type 1 diabetes for sure. And fat typically at higher and higher levels ultimately appears to blunt the impact of insulin to a degree. And so ultimately, for many people, they need to be conscious of that effect, right? So if you look at a lot of studies that show co-administration of fat with other nutrients, whether it be carbohydrates or protein, you see that it reliably alters the glucose curve, and in some cases can have a powerful effect on insulin as well. And how that appears to be happening is, number one, fat obviously slows down the digestion of the food in the stomach. But number two, fat can have at least higher in higher and higher levels, a dose-dependent impact on how effective the insulin is in the tissue or on various tissues. And so it is, number one, something to be conscious of. And the most important thing, because obviously I don't know this person, I can't necessarily give them clinical advice. What I can say is a pretty universal tool no matter what, is you have to pay attention. So when you try something like what type of fats are you attempting to measure or implement, you need to understand why are you doing it? What's the reason? Are they trying to improve performance? Are they trying to lose weight? Are they just trying to get glycemic control? If they're trying to induce performance, then they need to think about the type of fats they're consuming when they're consuming them around exercise. And also ultimately the insulin response to that. If they're doing it to ultimately get glycemic control, then they need to consider the interaction between how fat, when mixed with other nutrients, is going to affect glucose curve and ultimately the insulin requirements of that glucose curve, because it will change not only how glucose assimilates into the blood, but also the effectiveness in the insulin that's administered. And that also appears to be on how much they're consuming over that period of time. So it's quite a nuanced question, actually. For myself, what I typically do is there's a key difference between consuming a food with a lot of fat versus, obviously, like extreme example is consuming like a protein-based shake that has virtually no fat in it versus having a whole foods based like something like a steak where it has a lot of fat in it, particularly something like a ribeye or some other type of meat that has much higher fat. And in this person's case, maybe they're consuming if they're vegan or vegetarian, maybe they have a lot of coconut or some other type of healthy fat that is, consistent with a vegan or vegetarian approach. And they're consuming that with their protein. They do need to be mindful of the volume of that fat. They need to be mindful of what they're consuming it with. Because if it's, for example, if I were to be consuming something like, let's just say, this is an easy example on a vegan vegetarian approach. If I'm consuming some type of healthy plant-based protein and it's 50 grams of protein, I eat the plant-based protein by itself. And then I have coconut milk with it to kind of give it an enhanced flavor or fat profile, something like that over here. And I had, let's say, 50 grams of fat with it. This will absolutely change the type, it'll change how quickly that protein gets into the body, and also how effective the insulin is with that protein, because protein is going to have a more delayed prolonged effect compared to glucose. But when you add fat to it, it does change that curve, and it also changes how potent that insulin would be. So you have to be mindful of that, and just be conscious of the fact that it can change the amount of insulin administered often, and the kinetics of the glucose response as well. So if you see changes in glucose, you see changes in how much insulin you actually need, that's not unexpected. In fact, that's completely expected based on the science.
Thank you. I do throw in a bit of MCT oil in my protein shake just to manage the glycemic control better.
Yeah, so MCTs, for people who are unfamiliar, are medium chain triglycerides. They rapidly digest in the stomach, ultimately are converted in the liver rapidly to ketone bodies. And so if people are interested in this combination of ketones plus healthy fat interaction, medium chain triglycerides are often pretty cheap too, depending on where you buy them from. You can buy, the Ferrari of MCTs, or you can just go get some regular MCTs as well. They're basically the same. Although it depends on who you talk to. Some people disagree with that statement, but ultimately they are a healthy form of fat for many people. Only thing to be mindful of MCTs is that MCTs, if you consume very high levels quickly, can have GI intolerance issues. And so if you are going to introduce MCTs as a fat source, I highly recommend you slowly introduce it into the diet. Otherwise, you might have some unexpected GI issues and might want to be close to a bathroom. So be mindful of that, and take your time with introducing MCTs into the diet.
Absolutely. Thank you. And Dave, any questions before we
Uh,
wrap it up?
no questions. It's just been an amazing session. I love hearing you talk. Yeah, I was worried that you might be talking in a sophisticated way, and it might be not something an audience can relate to. But you absolutely nailed the point. You got it like in the simplest form possible, and I'm pretty sure everyone will enjoy it.
Well, it's an honor to be here, guys. I truly appreciate it. And at its core, I'm a patient myself. I'm an individual who wants to be healthier. I want to perform better. I want to live a high quality of life, independent of my disease in general. I want those things, period. And so I never went into the journey of science because I wanted to understand why this enzyme affects this. I did it because I was fascinated to understand why things were happening in my body. Why was I seeing this change, or why is this affecting me this way? And how do we, one, understanding that alone provides powerful tools. Because, for example, I often used to ignore fat, like your listener's question was. I'm like, I ignore fat. I was told by my doctor it doesn't have any effect on my glucose. Well, when I actually understood science and became educated on science, I realized that's not true at all. Fat has absolutely effect on my insulin requirements. And the type of fat, when we administer the fat, what you administer with, all these things matter. And you never see that more potently than in the context of type 1 diabetes. And so I just became fascinated with how how science and biology, physiology all interact together to provide this powerful opportunity to learn so that you can ultimately apply it into your own life. And so for me, that's really what it comes down to. If you do all this advanced work and science, from people ranging all the way from those dealing with chronic metabolic diseases to the best performers in the entire world, what does it matter if someone doesn't actually able to take that and apply it into their life? That's why I do it. I'm fascinated because I want to see the end user, the patient, the performer at the end of the day to live a better life, because that's what it did for me. When I walked into my doctor's office for the first time and had a powerful effect of how nutrition and exercise affected my life, it was very clear to me how powerful these approaches could be. But that's what stimulated my interest, was actually seeing the impact of it. It wasn't necessarily, like this biomarker went up or down. No, the only reason I cared about that biomarker going up or down is because I felt better. I performed better. I interacted better. So it affected my life and today in this moment. And so that's why I care. And that's ultimately at the forefront of my mind at all times with the science we do. No matter how complex or complicated it gets, it's very important for people to understand how to take that and utilize it. And that's why a lot of what I do is, and that's kind of a main goal of mine, is to put out information it's helpful, and almost all of it's free. I don't know anything that's paid. Actually, that's all out there for people to utilize and absorb. And my website is one of those places I've tried to dump almost all of that information for people to get. It's not completely updated yet, but if you pay attention in due time, you'll see there's a whole bunch of new information out there. Again, just to help people on their own health journey.
Thank you, Dr. Koutnik, for sharing such valuable insights on the Healthy X Sundays podcast. It's been an honor to have you with us. And whenever you publish your next research, please do come again on our podcast to share your insights.
Hey, you guys look out. There's a big one coming soon. So hopefully we'll get a chance to speak about it.
Awesome. Thank you.
All right,
Take
guys.
care.
Right.